All right, everyone, welcome back. Again, this is another episode of the Insights podcast. As a reminder, Insights, the content we talk about here, is based on the content from the on-call chapters published by the Neurocritical Care Society. This is a continually updated online guidebook that really provides just a rich wealth of content curated by experts. And Sally and I are so excited to get to distill some of that content, but we really invite you to go and check out the chapters as well. We are so grateful to our sponsors, Biogen and Cerebell. And now a word from one of our sponsors.
Time is brain when it comes to seizures. Cerebell Point of Care EEG empowers the bedside team to detect or rule out seizure activity in minutes. To learn more, visit cerebell.com.
All right. So in the last episode, we sort of went through, how do you approach a patient that you suspect might have subarachnoid hemorrhage? What is your sort of diagnostic algorithm? What are the things that you're worried about in that acute management for a patient who does have a very highly suspicious aneurysmal pattern subarachnoid hemorrhage? This time, we're going to spend a little bit more going through some of the medical management, not so much the surgical of clipping versus coiling, but the medical management of these patients once they get to a neuro ICU. These are, I think, some of the most challenging and engaging and just really rewarding patients to care for. Just to kind of think about this in sort of a broad perspective, you have sort of part one of an aneurysmal subarachnoid lifespan, which is just stabilization, preventing re-rupture, treating herniation, preventing herniation, and then treating hydrocephalus. Part two sort of starts once that aneurysm is secured, the hydrocephalus, if it's present, has been addressed. And now we're really entering a phase that's going to last, for that initial period all the way through 21 days, where you think about trying to diagnose, screen, prevent delayed cerebral ischemia. So, to be clear, vasospasm and delayed cerebral ischemia are not quite the same thing. We often talk about vasospasm and preventing vasospasm and treating vasospasm, but it's really important to know that vasospasm is one sort of biomarker of who's at risk for delayed cerebral ischemia. We know that this is a very complicated, complex phenomenon that involves cellular missignaling, cytokine release, and sort of a much more complicated thing than just the blood vessels narrowing. However, it really is important that we screen and we look for vasospasm. And so one of the things that I really like about the new guidelines in the on-call chapter is that you get a sense for just how accurate some of these screening techniques are. I think at many, many centers, transcranial Dopplers are sort of the bread and butter of screening. The pooled estimates for TCDs to diagnose vasospasm have a pretty good sensitivity of almost 90%. They're not quite as specific. So they're good at finding vasospasm. But again, vasospasm is just one biomarker of who's at risk for delayed cerebral ischemia. This is helpful, and I think we use it because it's very sensitive. CTAs certainly have a higher sensitivity for detection of vasospasm when symptoms develop. And I think we're getting more and more data about using CT perfusion to kind of understand who is actually having dysregulated perfusion to parts of the brain that might be at risk of delayed cerebral ischemia. The final thing that we're using or some centers use quite frequently, and I think there is evolving evidence for, is using EEG. We know that patients who have late onset epileptiform abnormalities probably have some perfusion abnormality going on to cause those late onset epileptiform abnormalities. And it seems like for those patients, there does seem to be a higher correlation of who goes on to develop delayed cerebral ischemia. We know that when patients develop symptoms, they benefit from often catheter-based therapy and angioplasty. But we as neurointensivists, we're really interested in trying to react before patients develop symptoms of DCI. Salia, I know kind of within our center, we're using more and more of IV milrinone. Talk us through some of the things that we should watch out for those patients who get put on milrinone?
Yeah, for sure. I think, as you mentioned, Casey, we do have some patients that are refractory, and by refractory, we mean that even despite being on oral nimodipine, which is, gold standard and our usual care in these cases, they still have evidence of DCI. There is some evidence on TCD or, CTA or CTP, or as you said, EEG. So these are the patients that are very complicated, and these are the patients that we're looking for different strategies, pharmacologically or non-pharmacologically, to help them. So IV milrinone, as we all kind of know in critical care, is an inotrope, and the idea behind it is that by giving this agent, you are going to improve and increase your cardiac output. And the hope and the goal is that by improving your cardiac output, you're going to increase perfusion to the brain, or cerebral perfusion. Now, a couple of things when it comes to IV milrinone, just because I feel like we don't use it as much as other, agents. First thing is that it will cause a lot of hypotension. So it comes with that big price, and we find ourselves, usually, at least in our institution, that we have IV norepinephrine and IV milrinone kind of running at the same time. And then the other piece that is really important for people to note is that milrinone is renally cleared, so it will stick around if your patient has renal failure. You have to adjust it for renal impairment. So it's not as clean as a lot of other vasoactive agents, such as norepinephrine or phenylephrine or other agents.
Absolutely. I really do like this a lot. I've seen it be very helpful in preventing patients from needing catheter-based therapy. Another one of my institution's favorite drugs of choice is intrathecal nicardipine. So walk us through a little bit about kind of what some of the studies show on that, and maybe kind of the evidence that we have so far.
We've done this, from time to time. I think there's a role, and I think, where this is coming from is that when we do calcium channel blockers, like nimodipine, which is, again, really the only agent that has been shown to have the most benefit when it comes to neurological improvement, from early studies that's been done. I think the idea and the problem is that a lot of other calcium channel blockers, like IV formulations, will drop the blood pressure so much that there's always this concern that even with nimodipine, we have the concern, right, that it's going to drop your MAP, that is going to come with that price. And sometimes you have to choose between your augmentation of MAP and your, nimodipine. We don't want to get into that debate because I know everyone does it differently. But I think the idea behind nicardipine intrathecal or intraventricular, which is some institutions do, is that you get the local benefit of a calcium channel blocker without the systemic side effect of it. It's a lower dose. It is very targeted. It is easy to give. Again, like we typically do the intraventricular, which is you have the EVD, you put it in, you kind of, let it sit there, and then you basically drain after an hour or so. Now, the evidence behind this, there is, to my knowledge, there is no randomized control trial. All that we know is observational studies. And based on the observational studies, some of which are actually published in neurocritical care, there is some evidence that this could possibly be useful in this population.
Absolutely. And I think, again, the guidelines really emphasize that we really don't have enough data to include these. And it is sort of center specific, and what centers are comfortable doing, what they've become accustomed to, how they use it, and the protocols that are in place. One of the final thing that sort of has been interesting recently is the effect of lumbar drainage of the blood that's sort of sitting in the basal cisterns. This, in the guidelines, just said, there may be a role for lumbar drainage to prevent DCI. Right after the guidelines were published, Early Drain was just published recently, that maybe does show that there is a benefit of draining from below and trying to use the gravitational pull to get some of that, cytotoxic blood out. But I think, again, we're going to need more experience. We're going to need more evidence before that really makes it into the guidelines. So, these patients end up on a lot of drugs, nimodipine being sort of the real evidence-based way to prevent or to improve functional outcomes. Magnesium, statin, Salia, what's the final word on those?
I think, this could be a hot debate and we could talk about it for days, but the short answer is that not routinely recommended. And I think that's probably honestly the best answer. I mean, could you give magnesium for pain? Sure. Could you keep someone's, statin that are already taking from home? Yes. But I don't know that adding it with the intention that it's going to improve DCI is something that we know is, going to be helpful, at least as of now with the evidence that we have.
The other thing that the guidelines really shifted on and is that we're pulling back on who needs continued anti-seizure medication. So what are we supposed to do about the patient who's not seizing in the ICU? This is a person we've never seen seize, but someone said like, oh, they had a seizure at onset. What are the guidelines saying about that and sort of anti-seizure recommendations in general, anti-seizure medication recommendations?
Yeah, I think something that, you and I kind of talked about a little bit offline is that if you think that they seized, but there is, no objective evidence that they seized, it looks like the recommendation is do 7 days of anti-seizure medication, avoid phenytoin, and that's it. But I think we all agree that if you see someone seizing objectively on EEG in your ICU, that's a different story. You hook them, to EEG, you're going to keep your anti-seizure medication and, close monitoring, and then future plans with the neurology or neurosurgery team as far as how many more days are they going to get discharged? Are they not going to get discharged? But I think if there is suspicious that they seize, but not proven, you could do 7 days of anti-seizure medication and kind of prevent all the confusion about, okay, like maybe we missed the seizure or something like that. But if we're actively seizing, I think that's a separate kind of discussion.
Absolutely agree. I think we're going to keep treating the patients that are seizing with their anti-seizure medications. I love it. Avoiding phenytoin because of that drug-drug interaction with nimodipine that we talked about last time, and the fact that we know that this leads to poorer outcomes. But all of these patients, when I round with students in the neuro ICU, I frequently hear, why is everyone febrile and why does everyone have this low sodium? So what are we doing about all of these hyponatremic patients? And what do the new guidelines have to say about that?
Yeah. So I think, as a pharmacist, the first thing that I think about are there any medications that can do that? And, that's why we typically don't allow any thiazides for these patients or anything that could drop sodium that we can identify. I think, just like anything, the first question that comes up when we round is that why are they hyponatremic, right? Is this cerebral salt wasting, which I feel like in the majority of the cases is probably the likely diagnosis in these patients, or is this, SIADH, or is it something else? Obviously, if you know what's happening, then it's easier. If it's, let's say, cerebral salt wasting, I think there is a lot of discussion about what about fludrocortisone, and the guidelines actually, I was really impressed that they said you could do fludrocortisone. It will fix your number. It will fix your sodium. But guess what? It won't change your DCI outcomes. And I think that was important to note. But the key point really is that if someone's hyponatremic and they're symptomatic because they're hyponatremic, I think we all agree that regardless of the etiology, you have to give them the hypertonic saline to get them to the goal that you have. So although, working up why they're hyponatremic, and let's say if they're SIADH, obviously, I think that becomes a little bit more tricky because fluid restriction in this population is a tough discussion to have. We want to, have them euvolemic because we know that's evidence-based to improve outcomes. So we have to kind of have that discussion and see what direction we're going to go. But if it's cerebral salt wasting, I think fludrocortisone is an option. You can still give them, fluids and salt, meaning, normal saline if they're very low, hypertonic saline if they're very symptomatic. Again, if they're herniating, obviously more concentrated sodium, like 23.4%. So I think knowing why they're hyponatremic is important to fix that. But just like any neurological emergency, if they're actively symptomatic, then hypertonic saline is a very fair and reasonable choice here.
I feel like we could spend literally like the next 4 days talking about the guidelines, how fascinating these patients are. But I think this has been kind of a nice discussion for if you're, rounding for the first time in the neuro ICU and you're seeing all of these complex management strategies play out. I mean, this is a place where there is still a lot of equipoise about how do we best manage and prevent DCI and all of the sort of neurologic complications and the systemic critical care illness that can go along with these very sick and complicated patients. I feel like this is what makes neuro ICU so fun.
I agree. And I think, when these guidelines came out, there was some, discussion about, oh, like it doesn't say do this and this and that. There's a lot of discussions about, well, we don't know. There is no evidence. But as you said, I think that's the fun part. That's the beauty of this, that you kind of do your own assessment, you read the literature, and you can make that clinical judgment by looking at the patient as opposed to kind of following a recipe for every single patient.
Totally agree. All right. Well, I think that brings us to the end of this episode. It has been so much fun. Talia, any parting words?
I think we covered it all. We covered two different guidelines, and hopefully people can learn something new or add comments if they wanted something more or different that we didn't talk about.
Yeah. And we definitely invite people to look at the on-call chapter, which has even more than we could possibly ever go into in these short episodes. All right. Well, thanks, guys. It's been fun.
All right. Thank you. Bye.
Bye.